So I want to talk to you about eccentric calcium specifically. Is it all risk and no reward? Well, eccentric calcium is probably the most common morphology in calcific lesions. And unfortunately, it may be the most difficult to treat. In fact, in this series of over 1,000 arteries that were examined by IVS, only 11% or so were concentric in morphology. And you can see that the majority of the morphologies were some degree of eccentric, between 90 and 180 degrees. The trouble is, though, that morphological patterns rarely occur in isolation. In fact, morphologic heterogeneity is the rule. In a long calcific lesion like this one, we almost always see multiple different morphologies. For example, more distally, we can see a calcific nodule. In the mid, there is a plate of eccentric calcium. And more proximately, there is near enough concentric calcium. So, even though we know it's there, unfortunately, we frequently don't identify it or take any notice of it. And that's because it's hard to see on plain coronary angiography. In fact, for you to be able to appreciate eccentric calcium on a plain angiogram, there has to be about a 100-degree arc of calcium. It has to be about 4 millimeters in length. It has to be quite thick, at just over 0.5 millimeter. And this difficulty means that even when the arc is greater than 180 degrees, we still miss it about a quarter of the time. So let's take this as an example. This is an angiogram of the left coronary artery. And it's not the worst angiogram I've ever seen in terms of its quality, but can you appreciate the calcium here? I'd suggest you can't. Well, I can't see it anyway. But when intracoronary imaging is used, which is of course much more sensitive, you can see there is quite a big arc of eccentric calcium. And this is just at the distal left main at the bifurcation. So what can we do about it is the next question. I think it's important next to understand the devices that we have at hand and what your options are in the cath lab to modify eccentric calcium once you've identified it. And ultimately, there are only really two things we can do. We can either change the compliance of the calcium, or we can reduce its volume. And so these are the main devices that probably you all in the room and myself at home has at hand to modify calcium. We have balloon-based devices, simply just NC balloons. There are specialist balloons like scoring and cutting balloons, ablative technologies or atherectomy, and there's intravascular lithotripsy. If we just think about balloons to start with, how do they work? What is the mechanism of action when a balloon modifies calcium? Well, balloons deliver undifferentiated circumferential force. The force is applied in all directions. And the higher the pressure, at some point, the more likely it is that the calcium will crack. And you can think of it like a ring of people all holding hands with a tight grip. If you were to exert force from the center in all directions, you can expect that at some point their hands would break and you would overcome that resistance. But eccentric calcium, of course, is different. The hands are only joined on one side, and there is little resistance on the opposite side. And so when an NC balloon is inflated in this situation, in an undifferentiated way, the force is pushed out in all directions. And of course, the hands don't break, because the path of least resistance is on the opposite side, and the balloon will expand away. So this really makes eccentric calcium a risk factor for perforation. And perhaps this is a risk that we probably underappreciate. It's pretty clear to see the lesion in the mid-LAD here. And when we image it with intracoronary imaging, of course we see quite a dense, thick ring or an arc of eccentric calcium here. And so, as is often the case, a non-compliant balloon was taken to this lesion. And if you look at that, what do you think? The balloon's gone up quite well, probably. Well, you might guess what's coming next. This was the result. Now, I don't think the balloon was oversized, but this is what happens in eccentric calcium. And if you take some data that was recently acquired at St. George's by Professor Spratt and his team, they looked at 37 perforations, which wasn't that infrequent. It was just under 1% of all of the cases performed. They did a lot of imaging to assess them, of course, and they found that when a perforation occurs, exactly 90% of the time, the causative device was in fact just the balloon. And if they went back a step, they would see that just before the perforation occurred, 75% of the time, the balloon had been expanded in an eccentric fashion. Because most of the cases were imaged, it was possible to go back and then assess what did the calcium actually look like. And unsurprisingly, 90% of these cases had eccentric calcium. So I think probably it is an underappreciated risk, and it shows that in this series, it accounted for most of the perforations. So thinking about other technologies, what else can we do? Well, of course, there is atherectomy.
Can we have one more minute, please?
That's very generous, thank you. I'll do my best.
We are very short in time, that's why.
Thank you. Well, this is debulking. So we talked about modification of compliance, and this is instead shaving off some of the calcium. But of course, the atherectomy burr has to be in contact with the calcium in order to do that. Now, in a small lumen, that's going to happen. It's going to touch it. But it is possible to have either of the two other scenarios where there is favorable or unfavorable wire bias. If we just look at this case example very quickly, this is an uncrossable mid-RCA lesion. An atherectomy was performed. And you can see in the imaging that at the green site of MLA, there has been some modification. And more proximally, where the red circle is, there's also been some modification at the top. But at the bottom of the image, there is a big plate of eccentric calcium that has not been touched. So what do you do? Well, I'll take a bigger burr then. But of course, that burr is still not going to get anywhere near the contralateral eccentric plate, even if you make it bigger. Can I have maybe another 30 seconds?
Yeah, that's fine. 30 seconds.
And I promise I'll go to the punchline. So IVL is different in the way that it works. It's selective for calcium, and it's not affected by wire bias. And as long as the balloon is in contact with the calcium, energy will be delivered to it. We know that irrespective of the arc, whether it's eccentric or not, shockwave will have the same outcome in terms of minimal stent area. And in this previous case, you can see that post-IVL, there are in fact some cracks now in that eccentric calcium at the bottom. So when you have multiple morphologies, it may be that we just have to use multiple devices with different mechanisms of action. And of course, IVL is helpful for several reasons, but it's safe and it's effective. It selectively targets calcium, it works in all the morphologies, and the outcomes are consistently predictable. And one thing we see in all of the data is that shockwave is safe. So in summary, it's okay, you don't have to put it back up. In summary, we know that eccentric calcium is a big problem. And when we decide which of our devices we intend to use to treat it, you have to consider the mechanism of action. Intravascular imaging is useful because it helps us to understand wire bias as well as morphology. And shockwave is probably the only one of all of the options that is still safe and likely to be effective, irrespective of the morphology that you're treating. Thanks very much.
Thank you, John.